So if I think of metabolic acid-base disturbances, I have metabolic acidosis with anion gap or an anion gap metabolic acidosis. I have non-anion gap metabolic acidosis, and I have metabolic alkalosis. In anion gap metabolic acidosis or metabolic acidosis with an anion gap, mud piles is the mnemonic that will help you figure out what are the potential causes. For an anion gap metabolic acidosis, think mud piles, methanol, uremia, DKA. P is there as a placeholder. There is a drug that's not used very much anymore. It begins with a P. I remember it was an anticonvulsant, I believe. I forget the name of it, but it's not really used anymore. So they just left it there as the placeholder. So methanol, uremia, DKA, placeholder, iron, lactate, alcohol, or salicylates. So if my patient has a anion gap metabolic acidosis, think of mud piles, methanol, uremia, DKA, iron, lactate, ETOH, salicylates. If my patient has a non-anion gap metabolic acidosis, the first thing you should be looking for is diarrhea. Other things you can be looking for is Addison's disease, carbonic anhydrase inhibitors. Think of what Addison's disease does with your potassium. That kind of puts that into play. And type 1 renal tubular necrosis or renal tubular acidosis. Metabolic alkalosis, look for vomiting first. The other thing that can cause metabolic alkalosis is Cushing's disease. Again, many other things can cause these, but these are the most common causes. So then what if I'm doing if I have a metabolic acidosis and it's an anion gap metabolic acidosis, and I do the calculation of the delta gap plus the bicarb, and it comes to less than 22. Then I know I have a metabolic anion gap acidosis, but I also have a non-anion gap acidosis going on as well. So then I would look for one or more of my causes of the anion gap acidosis, plus I would be investigating for the causes of the non-anion gap acidosis. Just like if the patient had a metabolic anion gap acidosis, and I did that delta gap plus the bicarb, and it was greater than 26, now I know the patient has a metabolic anion gap acidosis plus a alkalosis process going on. One of the things I could be thinking about is a metabolic alkalosis, and I'd be looking at is the patient vomiting or is there Cushing's disease? Two most common causes. Causes of respiratory acid-base balances. Acute respiratory alkalosis can be caused by asthma, can be caused by anxiety, right? We're blowing off CO2. You are constantly blowing in asthma or anxiety type states. You might become hyperventilatory, tachypnic, you're blowing off all that extra CO2, and now you're putting yourself into an acute respiratory alkalosis. Chronic respiratory alkalosis, honestly, the most common cause is pregnancy, resultant from the hormone progesterone. Progesterone actually increases respiratory rate, and they're exposed to it at higher levels for so long. When you're pregnant, you're breathing a little bit quicker, sometimes without even realizing it, and they can go into a chronic respiratory alkalosis until the pregnancy is over and the progesterone returns to normal. Then on the acidosis side, acute respiratory acidosis, think COPD exacerbations or narcotic use. So in COPD exacerbations, we are retaining CO2. In narcotic use, if it's affecting the respiratory drive and they get respiratory depression, again, affecting acutely the CO2 levels, they're going to retain them, lead to an acute respiratory acidosis, chronic respiratory acidosis. Your main example here is going to be chronic COPD.